Welcome to the MedEvidence podcast. This episode is a rebroadcast from a live MedEvidence presentation.
And welcome to our cholesterol horror nights. So who here has gone to any kind of Halloween horror night celebration? Okay. And who hasn't gone yet but is planning to go before the 31st? A few people. Well, I did actually take my adult kids to Halloween Horror Nights at Universal Studios, and let me tell you, the lines are much scarier than the houses.
That's the truth.
So just a little piece of advice. But when we were talking about this, and I was actually planning the trip with my children, I was saying, you know what? What's even scarier than Halloween is cholesterol. And I had a colleague, Al Lopez, here, who's we've worked arm in arm for many, many years. Al is a tremendous internist, runs a practice that recently merged with Millennium.
That's correct.
Physicians. And he's been passionate about treating lipid issues, cholesterol issues, for many, many years. And he's also a clinical investigator that is currently running some neat trials that he'll get to tell us about. So today what we're going to do is get everybody up to speed on why cholesterol is something that you should be afraid of if you don't understand it. Once you understand it, you don't have to be afraid of it because we have ways of keeping the goblins away.
Absolutely.
So anyhow, Al and I are going to run through you, and I have to say, you actually beat me with that wonderful tie. I was going to wear my vampire shirt, but I'm seeing patients later today, and they may get the wrong impression. So without further ado, again, thank you everybody for coming.
Actually, that shirt might be really appropriate for a cardiologist.
Well, that could be. And as you know, for people that have come here before, there's no such thing as a free lunch. You may think you're getting a sandwich, but in fact, you're getting a sandwich with some caveats attached. Obviously, we'd like to get to know you so that we can educate you in the future and be part of our MedEvidence family. By the way, thank you, MedEvidence family. You guys did a great job on decorating these slides. There's Chase in the front. I'm going to take a bow.
As always.
And we had our whole team here ready for you so that at any point, if you want to give us a little bit of information about you, we can make sure you get good medical information so that you just learn. Our first mission is just to educate the public. And our second mission is hopefully get people involved in clinical research because there's actually a lot of benefits and a lot of value for patients in clinical research.
Absolutely.
And I always like to remind people that when somebody has not done a clinical research program before, and you ask them, are you interested? Only 40% of people say yes.
Interesting.
But once they've done a clinical research program and have finished it, 97 to 99% of people say, I'll do a second one. So how many products or services can you think about where there's a lot of skepticism before you get exposed to it, but once you've had the experience, then you become a big fan?
Not as many as research.
Yeah, well,
sure.
there's probably very, very few. So that's something I always like to remind folks. So anyhow, getting back to our audience questions. Again, this is where you participate and you earn your lunch. So which of the following should scare you as high cholesterol warning signs? Is it A, xanthomas, which are yellowish fatty deposits on the skin or around the eyes? Is it B, chest pain or discomfort during exertion? Is it C, erectile dysfunction in men? D, peripheral arterial disease or claudication? Or E, cognitive difficulties outside of failure to address the honey-do list? So, what do we think about this? There may be one more answer, I guess. There we go. All right. So, do we have to go through all these, or does everybody know the answer? Oh, there we go. All the above is right. So, Al, why don't you comment maybe something that might be a little bit different than what people expect is erectile dysfunction in men. How does that relate to cholesterol
Actually,
issues?
that's the first one I was going to bring up. Everybody thinks it's the big T, right, your testosterone. And yeah, that's kind of true, but not really. But not to be too graphic, if you can't get, blood into that tissue, you can't float the boat, so to speak, right? So, you need blood in that tissue to develop an erection. So many will develop erectile dysfunction. It's a really early sign of cardiovascular disease. And it's long forgotten because everybody's enthusiastic about their testosterone, which is helpful, but it's not all about that.
And how about xanthomas? People may not be familiar with that term.
Generally, it looks like somebody took spackle or, mortar and kind of sprayed it on somebody. And you commonly see that on the back of hands, under your eyes, maybe your elbows. Your Achilles tendon is the most common area. So if, the doc says, let me check your ankles, they're not just checking your pulses. They may be checking that Achilles tendon to find that fat kind of hard plaque in there. And that's a deposition of cholesterol in those tendons.
Yeah, I'm sure you've had the same experiences. I'll be at a grocery store, and I'll see somebody that has a xanthoma under their eyes, and I can't resist by saying, have you had your cholesterol level checked? And mostly they have, but not always. Have you had that experience?
Several times.
Yeah.
It's funny, after you go to med school, you start seeing all these things and start diagnosing as you're walking down the street at a grocery store. It's a little scary.
All right, audience question number 2. Why do doctors treat with statin medications? Is it A, to treat a family history of heart disease, B, to treat low HDL cholesterol, C, to treat high blood pressure, to reduce heart disease and stroke, or E, or did you mean trick rather than treat? So we're not tricking people when we treat their cholesterol with statins, are we?
No. It's all about the evidence. And we can get into, the political aspects, but data is data, evidence is evidence, right? And you have to follow evidence. And when you do these trials, it's not a nilly-willy thing. You have to put a lot of time and effort into it. We're looking to make sure there's no bad outcomes. We're making sure there's no side effects. We're constantly asking questions, drawing blood to make sure there's no side effects going on. It's really time-consuming, but it's very rewarding when we finally get a drug that comes to market. And actually, we've done that. And we've been very lucky to have several drugs that we've been very successful with.
Totally. And at the end of the day, the correct answer is to reduce heart disease and stroke. And as Dr. Lopez says, we have a ton of information showing that these interventions make a difference. Not just in one study, but in dozens and dozens and dozens of studies. And every time the outcome is the same. And we're going to get into those key features of how we treat patients just in a moment. But now for the next audience question. This may seem like a silly question, but most people don't really understand exactly what cholesterol is. So let's see if we can educate.
Sorry.
What is cholesterol? Is it A, an essential molecule for cellular structure and function? Is it B, a fat molecule that does not mix with blood outside of a lipoprotein? Is it C, a cardiovascular risk factor that predicts heart attacks? Is it D, a pension plan for Doctors Lopez and Koren? Or is it E, all the above? So who thinks it's, well, why don't you just raise your hand? What do you think it is? Just shout it out. E. Well, you're all right. Whatever you say is going to be right because the answer is, in fact, all the above. Now, we don't have any stock in any of these statin drugs, just to be clear. But the truth is that there's a lot of heart disease out there. And as long as it's heart disease, there's going to be business for Dr. Lopez and myself.
Right.
So why don't you give us your perspective on how you try to explain to people the concept of cholesterol and the fact that every cell in the body needs it, but we're still trying to get rid of it.
So, cholesterol is vital for a lot of things. How nice your hair is, right? For how your skin is actually soft. To make hormones, male hormone, female hormone. It's essential for many functions, but when we measure cholesterol, we're measuring the remnant, the leftover stuff that your body has already been done using, and you're basically measuring the fatberg in your drain. It's the garbage. It's the leftover stuff. It's the stuff you don't want. And unfortunately, when it's high enough, it starts an accumulation process. And that will occur, unfortunately, in the vascular bed. And that's the vessels that go everywhere in your heart and hits every organ. So wherever it deposits, it's where you're going to have a problem. So it could be your eyes where you have visual loss. You'll have pinpoint visual loss or total visual loss. You may have a stroke, a heart attack, or disease in your legs. That's where the deposition is. That's where you have the problem.
Manifestations of high cholesterol.
Or other manifestations, absolutely.
Yeah, so if you get nothing else out of this lecture, the most important thing, and by the way, not all doctors know this and not all providers know this, but every cell in our bodies make cholesterol. And the stuff in the blood is the extra stuff we're trying to get rid of.
And that includes your brain, right, Dr. Koren? Because for often we hear, well, it's going to cause dementia. It's going to deplete the cholesterol in my brain. Number one, the brain makes its own cholesterol.
Makes tons of cholesterol. Your brain cells make tons of cholesterol.
And the statin doesn't cross that blood-brain barrier. None of the drugs do to reduce it in your brain. And actually, there's 14 studies now with over 7 million patients showing that it does the opposite. It reduces dementia.
Exactly.
So
that's a really, really important point. So even if you get your LDL cholesterol, the stuff we measure in your blood, down to 0 or near 0, your body still has a ton of cholesterol in the cells. So again, that's a really, really important concept that you can take home to other members of your family, friends, et cetera, and even remind your primary care physician, because not everybody knows that.
Or your cardiologist.
I won't argue with that. All right, so Al, so tell us kind of what the environment is. What's the landscape in terms of who's taking all this seriously?
So we've known for a long time, and part of why I kind of got involved in reduction of cardiovascular disease and lipids is that it is the number one killer globally and the number 3 disabler globally, and that's internationally. That's right. It's every country. And 7 out of 10 people have high cholesterol. And only about 5 out of 10 are living with actual heart disease. Maybe just that other 2% of that are not presented yet, or 20% is not presented yet. And only 2 out of 10 are on proper therapy. Whether it be statin or anything else, they're just not being treated accurately or effectively. Hence, my mission was hopefully by 2027 to reduce cardiovascular disease, the number 1 killer globally, to number 3 or 5, and I'm not sure we're going to achieve that, unfortunately.
Well, the sad part about that is we can if we can get people to take the treatments.
Right.
Obviously, you need to find out if you have a problem, and if you have a problem and you are at high risk, we have wonderful treatments to help. And so that's part of our mission, is to get that word out.
And you got to take it. You can't just take it home, right? It doesn't like seep into your, through the bottle into your fingers, right? Or if you lay it under the pillow, like we thought in elementary school, it'll absorb into your brain or your heart. It doesn't work that way. You got to take the pill.
Absolutely. Medications are only effective when prescribed and taken. So, we've made some progress in heart disease over the years, but more recently it's a little bit scarier. So walk us through these epidemiological concepts.
So, I've toiled over these numbers in this slide. We've made great efforts up until about 2016 and 17, starting to really reduce cardiovascular events. Death went down, side effects of cardiovascular disease went down, and then around 19 we see a big change. And that correlates with what?
Well, it's before COVID, just
right.
to be clear. It's actually, COVID made it
right.
worse, but it was actually before COVID.
Yeah. Well, COVID, we started seeing an uprise. And part of that was, if you remember in the 90s, right, there's Richard Simmons and Jane Fonda, and everybody was walking and exercising. People were really being a little more heart healthy. Mm-hmm. Smoking reduced.
Yeah,
so smoking really reduced, which has gone back up again. Mm-hmm. So we see a number of factors coming up pre-pandemic, but got even worse during the pandemic.
Yeah, so unfortunately, the last 10 years has not been as good as the previous 30 years at reducing heart disease. So we're here on a mission to get this trend line back on the right, moving in the right direction.
And the other thought is the misinformation out there. And I know I've said it once, but I'll probably say it another 5 times because it's very frustrating.
Sure.
I've been in a number of national and international advisory boards for cholesterol and heart disease, and they'll always ask, well, how do we reverse this? And we as clinicians and scientists and people in whatever, they're in healthcare, really have to speak more openly. If you go on the internet, you'll find 10, YouTube videos on how elevated cholesterol is just fine, and it's not going to cause you to have a heart attack, and that's such, disservice. Yeah, so we have to be out there doing our job, and that's part of why we do this today.
Yeah, absolutely. So talking about sudden cardiac death, which is the most common manifestation of heart disease. Again, people don't die of cardiac death that don't have heart disease. Some of them know they have heart disease and some of them don't. But just run us through some of the statistics here.
The conversation is that we know that in older adults, about 80% of the population has coronary disease. It's a function of time, but it's a function of risk factors that are elevated. So if you have higher risk factors, high cholesterol, at an early age, we know you're going to have heart disease at an early age. And we know this in people that have 2 family members that have really, really high cholesterol. They may start having heart attacks in their teens or their 20s. If you have moderate level, one family member that has really, really, really high cholesterol and the other one that doesn't, you may start having it in your 30s and 40s. But we all will start having around 50 or 60. And because you're having a deposition of this, cholesterol protein that you really don't need anymore. And it does occur in over 50% of the population. The first presentation of cardiac disease is sudden death. And if it don't, the outcome isn't very good if you don't get treated soon. The outcome is actually worse for women that don't get treated than men that don't get treated.
Exactly. And people who are older also still get benefits from treating cholesterol and other cardiovascular risk factors. And that's sometimes not emphasized in certain practices.
Well, if you look at the event rate, right, it's higher as the older we get, but there's plenty of studies that showed people over 70 have huge benefits in reducing events.
Probably the most benefit.
Yeah. And, unfortunately in the South here, it is unfortunately the stroke and heart attack belt, and it's a problem.
Yep. And we'll get to that. There's an old saying that the South starts north of the St. Johns River. So I just crossed the Hart Bridge, so now I am officially in the stroke belt of the United States.
Yeah.
And you can see here, this map kind of points that out. In the dark blue are the worst areas in the country for heart attack and stroke. Those are all the worst 10%. Florida overall is kind of in the middle, but northern Florida is actually much closer to the stroke belt than southern Florida, for example. And so Florida, being a very diverse state, has a bunch of different cultures, et cetera. But we here in North Florida certainly have very high risk in terms of geographical reasons why we want to get aggressive at treating heart disease. Any comments on that?
No, and it's getting worse. I mean, if we look over the last 20 years, I think the color of this becomes darker and darker, where 40 years ago, it was all this light lime green color, and maybe there was just a couple of belts that were that medium blue color, and it's gotten much, much worse over time. Yeah. And it's not a good thing.
Yeah. So we have a lot of work to do. Going back to our pension plan. All right, so getting back to the audience questions. Which of the following might haunt you? Is it A, HDL level that equals your LDL level? Does that haunt anybody? No, that's kind of a good thing, right? B, a low lipoprotein A count. Does that haunt anybody? Nah, no one seems to be too scared out there. C, a high CAC score for your age.
A little knee shaking.
Yeah, I think you should be a little scared by that.
Yeah.
That's the equivalent of having a chainsaw chase you down the street at Universal Studios. D, a strong family history of heart attack or strokes.
Yeah, that's a big one.
Yeah, and that might haunt you, but we also have solutions for that. So certainly it's something that doesn't mean that you should lose hope. And then finally, E. Come on, E. Come on out, E.
There it is.
Visiting a cardiologist.
That's scary. That's really
Now,
scary.
that really should haunt you. So, comments on that slide?
Cardiologists are scary.
Yeah, we are.
Oh, never mind. We know that it is people are genetically predisposed. If you have a strong family history, you've got something, and there needs to be an investigation on why your family has a high risk of heart disease. And that's been a mission of mine for a long time. And I was asked a long time ago, you must have a horrible family history of heart disease. I said, no, it's just something I think I can change. Mm-hmm. And hence I took the deep dive, and Dr. Koren was after me for almost 40 years, 30-something years, and tried to join him to do research. And I finally gave in about 15, 20 years ago. And It's probably one of the most exciting things I've done in my career. We really need to know what your family history is, and what event rate is and what age it happened. The younger it happens, the scarier it is. And as far as CAC scores, we'll talk about that coming up.
But how about HDL that equals your LDL? Explain that a little bit to people.
We know that HDL is presumed, and I say presumed because there's newer data that says that may not be totally true, that HDL may be your protective lipoprotein. And so if it's actually equal to your LDL, there may be a more of a protective effect. There is new data that says that people with very, very, very high HDL, it may not work as efficiently as those with medium level HDLs. So you basically have this keystone cop, and you don't really have a special ops guy in your armamentarium. But HDL equal LDL is actually a pretty good thing.
Yeah, so by and large, there's lots of epidemiological data that show that higher levels of HDL are beneficial. We've never been able to show that raising HDL artificially makes a difference.
That's true.
Whereas we have shown that lowering LDL with treatment does make a huge difference. So that's where it gets a little bit confusing. But in general, you want to have a high HDL level. And if your HDL level is as high as your LDL level, overall, we're pretty happy with that.
Pretty good place.
But even if you have an HDL of 80 and an LDL of 80 and you have heart disease, you're still going to treat the LDL.
Absolutely, always. And the HDL is kind of like that Ghostbuster big giant gun, you know? It just kind of like dissolves all those ghosts.
There you go.
It does pretty well.
All right. All right, so why don't you get into some of the key principles for treating cholesterol?
So, this is not new data. We've known this for close to 40 years now, right? And looking at, it's almost like a limbo contest, I tell my patients. It's lower and lower every decade I do this, and the longer I do it. But we're finding the data is very strong that the lower you get your LDL, the safer you are. And the sooner you do it, and it's the same analogy I gave before, right? People with really, really, really high cholesterols have a much dangerous chance of having it at an earlier age. And I kind of give the analogy of a piece of metal in salty water. If it's mildly salinated, you stick it in the salty water, 20, 30, 40 years from now, it'll rust. But if it's in really, really salinated water, it's going to rust a lot faster. And so LDL is really your internal rusting agent, right? It's going to cause a lot of problems. We know that people with the higher LDLs, if we treat them, even getting a moderate risk reduction shows huge benefits, but getting them much lower gives them a whole lot better risk reduction.
Absolutely. So these are all the key principles laid out. The sooner you make the diagnosis, the better.
Right.
The lower your LDL, the better.
And the longer you treat it, the better, right?
The longer you treat it, the better. But if you start out really, really high, don't freak out, because you actually have the most benefit to be gained compared to people that start lower.
Right.
And the greater your overall risk, and that includes family history and your weight and your smoking status and your blood pressure, et cetera.
Eating habits.
All these things mean that we can actually have a bigger effect by turning these things around. So don't necessarily have to look at that pessimistically. We like to look at it optimistically. Okay, so we have some both good news and bad news. So first, the good news.
So as we've shown in prior slides, we've made great strides in reducing cardiovascular disease, reducing it up to 50% over the last 30 years. Even that's starting to trend back up. And a lot of it is we know that we've learned how to eat better. So if you all remember in the 70s, 60s, we were taught lard is great, it's wonderful, right? We were told, go on a heavy carb diet, it's great for you. And we found that's not so good. The diabetes rate soared. So we told what we thought was good data at the time. We've learned a lot more that eating 7 to 10 servings of fruits and vegetables a day makes a difference. Lower fat diets, less red meat, movement therapy, because I don't use the word exercise because so many people are allergic to it, and it scares them really bad.
Movement therapy, I like that
But
one.
movement therapy works really well. The bad news, that there's still a huge number of Americans, almost 100 million Americans are affected, and about every 40 seconds, somebody in the United States has a heart attack. That's about 60 to 100,000 deaths a month, not a year, a month. And that's projected to get worse if we don't make a change. Mm-hmm. That includes what we eat, what we do, and the treatments that we initiate as clinicians, and you have to take.
Right. Yeah, so one of the things I find really interesting about these epidemiological data have to do with the availability of cholesterol drugs. So the first modern cholesterol drug, which was a statin called lovastatin or Mevacor, came out in 1987. And then a bunch of cholesterol drugs came out after that in the statin class. And between 1987, when that first drug came out, and around 2000, when the last one came out, which was Crestor, or rosuvastatin, we saw the most dramatic drop in cardiovascular death rates around the country. And so, not everybody has a favorable...
See, you're talking about cholesterol, and now that background spooky sound is happening.
Yeah. It's probably my staff doing their job. Thank you. But to finish up on the point, not everybody has the greatest impression of pharmaceutical companies, but I have to give them credit where credit is due. And in that case, they very aggressively promoted statins, and that actually resulted in fewer heart attacks, fewer strokes, and longer and healthier lives. So when you have a good product, you want to promote it and get it out there. And so cholesterol treatment is one of those places where we have tremendous products now, and we just need to use them appropriately and get them out there.
When we started with lovastatin, the percentages were okay. They were moderate reduction. When we got up to rosuvastatin, which was
Much more effective.
much, like almost double the effectiveness, plus the stroke rate went down and the dementia rate went down with that as well.
All those things. And then unfortunately, actually it's good and bad, the statins became generic around in the first decade of the 21st century, let's put it that way. They started to become generic, and there was less promotion, and now all you hear about is the bad stuff about statins on the internet, rather than all the good things that they do. So part of our job is to remind people that these are incredibly effective medications that people at high risk should be on.
And you need to monitor it. You can't just give it and expect nothing else. They don't do that with your blood pressure. They ask you what your blood pressure is. We don't do this with diabetes and just throw the drug at you and don't ask you what your sugars are doing. We as clinicians have to have you come in, and your responsibility is to get testing every so often and make sure you are at goal and that your liver's okay, because I often hear, well, it's going to kill my liver. Not really, unless you already have innate liver disease.
Yeah. In fact, we use statins to treat fatty liver disease.
Yeah, which is odd.
Right. So it's really not something that hurts your liver. It actually helps your liver to function better. That's actually how these drugs work.
Yeah.
So let's get into this concept of what we can change, what's modifiable and what's not modifiable.
Right. So we know part of this is genetic. It's in your genes. It's what's been given to you. So you can blame your parents for that one. And that's scary. And then the other factors are what you do. And they're about equal. But
So let's run into some of the actual details of modifiable risk factors.
So as we've talked about the lipid profile, what is your LDL? And that's probably the most important out of them. Triglycerides, it's more emerging lately that triglycerides are really important. If it's really, really high, the bigger chances you can develop pancreatitis if it's really high, but it also becomes something that produces plaque in your arterial walls. And then really low LDL we know is a risk factor because you're not making as much. Diabetes, even pre-diabetic. The pre-diabetic has double the risk of cardiovascular disease, and the diabetic has 4 to 6 times higher risk of heart attack and stroke. You really got to treat that. Being overweight, numerous problems with being overweight, and it's a constant battle for everybody after you hit 50. Lack of physical activity or motion therapy is really important. If you're going to eat greasy, fatty foods all the time, you're going to have a problem sooner or later. And we know smoking definitively, and we've seen this numerous times. I remember very clearly as being a resident, and a gentleman who was a huge couple-pack-a-day smoker had 2 stents put in, went home. In the car, he started having chest pain because he lit up and smoked 3 cigarettes because he was so stressed out from being in the hospital for a week. Wife turned the car back around, put him back into the cath lab, and he was spasming another artery and had to put another stent in.
Yeah.
So smoking is a definitive risk factor. High blood pressure. That arterial wall is just like a tube. It's only guaranteed for 120 pounds per square inch. If you put more than that in there, it's going to crack and pop sooner. And stress itself is not good because it sends a lot of hormonal reactions that are not really good for you.
Absolutely. And there's something that we can't do as much about, and these are listed here.
Yeah. So you really can't change who your parents are. I wouldn't want to, but some people might. Unfortunately, you can't change your age. My name's Lopez, not Ponce de Leon, so I can't do that. Age and sex, well, that can be arguable, but whatever you're born with is your risk factor, even if whatever you do. Your ethnicity, there's some of us that are higher risk than others, and that depends on whether it's cholesterol or Lp(a) or whatever, but different ethnicities have different risk factors, and weather, not so much. But weather is a problem because in the Northeast we do see it because we have gentlemen and ladies. I'm not going to be biased because I've seen my wife shovel snow when we lived up north. It's stressful. It's a lot of work. And you do that for 3 or 4 hours and you're giving yourself a stress test and you may not be in the shape you think you're in.
Right. And there's also, if the environment allows for you to do your motion therapy,
right.
You're going to do better if you're in an environment that is less conducive to that.
And we also know that the inflammatory response in getting viral illnesses also augments the inflammatory response systemically and increases the risk of
not to
heart
mention
attacks.
The stress of preparing for hurricanes or the stress that occurs after earthquakes has been associated with higher risk of heart attacks. But family history may be the most important, and I always like to tell people that my number one piece of advice for my patients is to pick good parents. So, all right, so let's talk about what a standard lipid profile looks like.
This is so frustrating for me because you'll get these numbers on the profile and then I'll get like the phone blows up, the portal blows up. Oh my God, my numbers are red. And sometimes they're not low enough. And what your optimal level is depends on your risk, right? So, total cholesterol is really not as important to me. It may be for Dr. Koren. For me, it's not as important because the only importance I have is in looking at risk ratios. Really, the LDL for me is the most important out of this profile. And yeah, we want it under 100, but if you have diabetes, it should be under 70. If you have mild heart disease, 70. If you have heart disease and had stents or open heart surgery or have strokes, then it should be below 55. Hence why I say, that depends. HDL definitely over 60 is better. Triglycerides definitely under 150, but there's more and more data saying maybe 100 or 125 should be the new level we look at. And then non-HDL is really important, but that also changes depending on your risk. So 130 for the average person with no real risk,
right.
But the higher risk you have, that number goes lower. So it's a giant limbo contest.
Yeah, and one pet peeve that both of us have is when you see this on your lab report, optimal level.
Yeah.
Because the optimal level is based on the patient. So the optimal level of LDL is not the same for everybody.
Mm-mm.
And in the high-risk people that we deal with, we try to get that LDL below 55.
Yeah, and I'm actually okay even lower than that.
Absolutely.
I mean, there's more and more data. Again, the lower the better. And, I've had people freak out saying, well, it's in single digits. It's like 12. And I'm like, better for you.
That's great.
You have less, you have less metal to rust.
Exactly.
Yeah, this is great.
And funny, very rarely, it's actually a negative number on the reports. And that's because a standard cholesterol profile just calculates. You see how this is calculated, and it's not directly measured. So don't freak out if you have a -2 as this number if you're on one of the modern PCSK9 treatments, for example, that are extremely effective at getting LDL way down. People will call, oh my God, it's an emergency, I have a negative LDL cholesterol. Well, I can guarantee you don't, and if we remeasure it directly, it'll be a low number, but not a negative number. All right, so moving on. I'll probably handle this because this is getting onto the nerdy stuff that I revel in.
He's more of a nerd than me.
I'm a big nerd. I first admit it. So, but fortunately, my staff decorated it so that it's not quite as intimidating with all the goons and goblins there. But anyhow, as I mentioned, we had our first cholesterol drug that had a big impact in 1987, which is listed here as Lopez. And by the way, just an interesting tidbit, I was a resident when Lopez came out, and everybody's always so worried about the safety of these drugs. We had to do eye exams several times a year. We had to check liver function tests on a monthly basis.
Yeah.
We had to check the thyroid level constantly. Really, it was this incredible safety protocol for somebody to get on lovastatin. And nowadays, when you're on a statin, the recommendation is you check labs once a year. That's it, because these drugs have turned out to be so incredibly safe.
So safe.
So as I said, this should be the standard for treating cholesterol issues in most people. Now, some people have true intolerance of statins, but it's a relatively small number. But that's your base. And then we have these other classes of drugs that are pills that either hit triglycerides or have anti-inflammatory effects or lower LDL. And these have all been shown to have an additional benefit on top of the statins. So these are all well-established drugs. Now, the new stuff that's coming out is pretty exciting. There's a drug in development for lipoprotein a called pelacarsen that we should be seeing shortly. Pelacarsen is a drug that's called an antisense oligonucleotide, and it's using now genetic ways of blocking the expression of certain genes, which results in very, very low levels of lipoprotein A. We have a number of drugs that are in the small interfering RNA category. These are drugs that, in this case, treats LDL cholesterol. In this case, treats lipoprotein A. We have monoclonal antibodies that have been approved. The first two are what we call PCSK9 inhibitors. These are drugs that have remarkable effects on LDL cholesterol. They lower LDL 60% on top of statins. They're absolutely remarkable. And they've been shown to have really profound effects on cardiovascular outcomes. In fact, there was just a evolocumab study that we participated in, Repatha, that just shows that it works not only for people that have had a previous heart attack, but for people to prevent a first heart attack. So we're really excited about that. We just got top-line information about that, and we should be getting the full scoop on that particular product at the American Heart Association meeting next month. And these are the ones that we're working on now in research, and I'm like super excited about all these things. There's a drug called obicetrapib, which is called the CTEP inhibitor. This is another drug that treats LDL cholesterol using a PCSK9 mechanism. We're now using pills. The one potential downside of some of the monoclonal antibodies is that you have to get regular injections. But we are working in research right now on pills that will have a very similar effect to the injectable agents. So we're excited about that. We're enrolling in studies that use these drugs as we speak. And the latest thing is that we'll probably be the first site in the United States to be able to give CRISPR therapy for a genetic dyslipidemia. So I don't know if you've been following that story, but CRISPR is a type of gene editing approach that has been recently approved for sickle cell disease in the United States. Mm-hmm. And we're really excited to be probably the first site to get up and going to have this accessible to patients here in Florida to treat genetic dyslipidemias.
And this is for life-threatening cholesterol levels. This is not for the average person, the majority.
When you say life-threatening, obviously all marked elevations are bad.
True. So
this is for people that have types of problems that don't respond as well. And I don't want to get into all the science, but it's called an ANGPTL3 inhibitor, which hits both LDL cholesterol and triglycerides and reduces your overall atherosclerotic burden. So these are all stuff that we're doing here. Literally here in Jacksonville, we're doing stuff that's state-of-the-art around the world. So I'm super proud of investigators like Dr. Lopez and my team for being part of all this. So,
and you, published for a long time.
And all the people in the audience that have participated. So it's a team effort, and it's exciting that we've been able to provide leadership in this area. By the way, atorvastatin is a Jacksonville drug. You probably didn't know this, but 12% of all the people that took atorvastatin or Lipitor before it was on the market came from Jacksonville because of our efforts. So, and that was the #1 selling drug in the world for many, many years.
So I wanted to make 2 quick comments.
Sure.
One drug may not work. Just like with hypertension and diabetes, you may have to use 1 or 2, sometimes 3 drugs, depending on what your body is producing and how it's producing that, right?
Good point, yeah.
And the body's pretty smart, so you may block a mechanism and it finds a detour route sometimes to make what it's going to do. And that's why sometimes we have to go by different mechanisms.
Absolutely. So we're going to run through these last few slides. These are like the sort of the new kids on the block. We talked a little bit about LPA, but just give us like a quick minute on this.
So LPA is kind of known the evil twin of LDL, and it's a little protein that attaches to that bad cholesterol in quotes molecule, the LDL.
It's this little squiggly guy here.
Yeah,
and I love the way my staff put the devil horns on that.
And it's almost like putting a turbocharger on a go-kart. It really makes it really aggressive. It makes it proathogenic, so you make plaque much more easily and make coronary disease or vascular disease much more readily. It looks like a protein that makes you clot easier, so it's prothrombotic, and then it's pro-inflammatory. It sets up a whole inflammatory cascade in the vessels, and it infects 1 in 5 people globally, which is really frightening.
Yeah. And we don't have any great way of treating it right now, but there's a few fun facts you can run through these.
Again, like I said, 1 in 5 people, so 20% of the population. You can give it to 50%. If John Doe has it or Jane Doe has it, they can give it to 50% of their children. So we should do what we call cascade screening. We should look down families and see who else might have it so we can prevent from something happening in the future. It has a marked risk for increasing cardiovascular disease. Again, it's like putting a turbocharger on LDL and activating it, making it much more plaque producing. And then you have to be careful what units you're doing it, and that's more for the clinician because there's 2 ways to measure it, and we're trying to come to a consensus on which one of these 2 should we do.
Yeah, and I think nanomol is kind of is kind of the leading way of doing it. But you may still get reports that talk about milligrams per deciliter. That's important because you may say, oh, my level is only 60, I'm looking pretty good. But if it was 60 and it was milligrams per deciliter, that's not so good. So knowing the units is actually
Yeah.
important. Hopefully the doctors will walk you through that.
And so you should know your LDL. And the feeling today, when I first doing ad boards for this, it was felt just ask for high-risk patients to have the LDL checked. Now the feeling is everybody should have their Lp(a) checked once in their lifetime. Why? Because by the time you're 3 to 5 years old, that's the level you have, unless we have a drug that's going to reduce it.
Right. And getting to that point, LPA is genetically mediated. It's something that you're born with that tendency to make. As mentioned by Dr. Lopez, if you have it, there's a 50-50 chance your kids have it. And if you have it, there's a 50-50 chance your siblings have it. And unfortunately, diet and exercise have virtually no impact on LPA levels. You can't treat it with lifestyle. And the only drugs that we have that put a dent in it are the PCSK9 inhibitors that lower it about 20 or 25%. But the stuff that we're working with in research can lower this by 95% or more, literally knock it out. So we're super excited about that. Okay, so I think we'll go over this. I think
Real quick.
Yeah,
And there are certain ethnicities that have a higher propensity. I mean, anybody is at risk for Lp(a), but it's much more prominent in the African American community or people from Africa, right? More prominent in the Indo-Pakistani peninsulas
Right.
and then Southeast Asians. But anybody can have it.
Yeah.
Anybody can have it, so you need to watch.
And again, the 2 points that we just made, I'll emphasize, is that the drugs that we have in the market only lower it by 25%. This is a dialysis type technique which pulls it out of your body, which is quite effective, but you literally have to go to a dialysis center every week. No one wants to do that. And as I mentioned, we have products that we've now worked with in research, including Dr. Lopez is leading a study on this, that can lower this bad
simple.
lipoprotein by 95% or more. This is pretty amazing. And these are just the list of the companies and the products that we're working on that will lower LPA. Many of these are actually enrolling as we speak. So if you don't know your LPA level, let us know. We'll check it for you for free. And if we check it for you and if it's elevated, then we'll tell you about what the opportunities are to get it down. And this is interesting. You came back from the a meeting and you had this little tidbit to share.
Yeah, and we're really pushing, what is your numbers, right? And this Lp(a), and actually only 70% of the physicians knew their personnel Lp(a) level, and only 50% of physicians knew their LDL levels, which is a little scary. So
Yeah.
here we are, you could be an ostrich if you want, but it doesn't really work.
Right, but the truth is that that's better than maybe the average public person. But the
That's
point
true.
is that everybody needs a reminder.
Everybody does.
And so we're here to educate and remind. And the doctors at this meeting were incredibly supportive of getting their levels down, but they weren't necessarily taking care of themselves as well as they were taking care of their patients.
Yep.
So we're going to just do a quick survey, because this is another hot area in treatment of cardiovascular disease, about hsCRP. Just a show of hands, who has heard of this before? Who has not heard of it? Okay, most people. Okay, so a quick education on this, because there's a lot of research and there's a lot of chatter about this, and I think it's useful to bring up. So what is hsCRP? Is it A, a blood test and marker for vascular inflammation? Is it 2, a politically correct way to express crap? Is it 3, outreach to the underserved CRP community? Is it 4, an acronym for high-strung, clearly ridiculous politicians? Or is it all the above? Well, it is actually 1. It's a blood test and marker for vascular inflammation. And that's another one of those numbers that you should know, because it does have an impact on your prognosis. And we actually are doing work on this in research as we speak. And one of the things we want to highlight is we have this educational platform called MedEvidence. And we like to talk about the latest and greatest. And I interviewed Dr. Paul Ritger, who's the world authority on CRP. Yep. And I've known Paul since medical school, so we're friends. But he did a great job at talking about why people should know this number as well. And it turns out that this is definitely a boo moment if you don't know about it, because hsCRP, of all the biomarkers, is probably the one that's most impactful in predicting the future. And I know that you also are a big fan of ApoB, so why don't you
Yeah.
explain that to everybody?
So ApoB is, again, another molecule that attaches on it's part of every bad cholesterol molecule, not of an HDL. So it's an easy way and a cheap way to look at what we call remnant lipoproteins and remnant risk factors. And so you'll see it on LDL, LP-little-a, triglycerides, and then subparticles, ILDL, and VLDL. And if those are elevated, then we know we need to do more work and take a deeper dive and figure out what your other risk factors are. And it's been shown to be an independent driver of cardiovascular disease, even independent of triglycerides or LDL in of themselves, in patients with or without known coronary disease or vascular disease. Mm-hmm. So we can predict by looking at this marker, ApoB, whether you might have an event along with HSCRP. It makes it even more sensitive than not. So ApoB has been a hot topic, and it's actually shown to be, you may argue with me on this, shown to be a little more sensitive than LDL in of itself.
Yeah, it's an epidemiological association, but the key thing here for the audience is to understand, one, that you won't get this unless you get an advanced lipid profile. So this is not part of the standard lipid profile. Two, that this is the protein in all the bad cholesterol molecules. So those lipoproteins are lipo, lipid, and protein, and ApoB is the protein part of the bad guy.
Right.
And so by putting all that together, you get a really good indication of what your risk is. And the truth is only very few primary physicians even look at this. And quite frankly,
actually
maybe a quarter of
anybody.
cardiologists.
Yeah, it's not a common test, and in my opinion, I think it should be a very, very common test and should be part of the the regular standard lipid profile.
Absolutely. And then I'll just make a quick comment on here. All these things are what we call biomarkers, which are biological things that you measure usually in the blood that tell you what your risk is. But looking at the anatomy is also important, and something that I do very commonly in my practice is I assess risk through something called a CAC score, or coronary artery calcium score. And here you can see the difference between somebody that has clean vessels on a CAT scan and somebody here who has a lot of bright spots, which is related to areas of atherosclerosis that are healing. And this is not on the inside of the vessel. These aren't necessarily blockages. This is more on the outside, in the middle and the outside of the vessel. And that represents healed atherosclerosis. So your body has the ability to heal atherosclerosis, and when it does it, it typically puts calcium on those lesions, on those areas, to stabilize them. And when you look at that over time, you get a good sense for the aggressiveness of the atherosclerosis process in an individual. And this is, of course, an age-related phenomenon. So if you have a 0 CAC score at 30, it's not a big deal. If you have a 0 CAC score at 70, you're probably not going to have a heart attack in your life. Whereas if you have even a CAC score of 20 when you're 30 years old, that's not a good thing. That means that the atherosclerotic process has already occurred. Right. So we use this a lot to predict prognosis in people and then guide our therapy either more or less aggressive. So this is our final audience question, then we'll go to general questions. But which treatment goal best reduces heart attacks or stroke risk? Is it an HDL of less than 40 and a CRP less than 2? Is it an LDL less than 70 and a CRP less than 1? Is it an LDL less than 120 and triglycerides less than 150? Is it LPA less than 100 and LDL less than 100? And the answer actually is that. Well, just in the interest of time, I'm just kind of giving the answer because it gets a little bit technical. But anyhow, the studies have shown that if you can get both the LDL and the CRP down, then you're in the best possible shape.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.